on my clock here in the basement of Silo Drive in Chapel Hill, North Carolina. So we're a small but hearty group today, which is not surprising given that there's a holiday weekend right around the corner. It used to be people would take off on Fridays, and now I think people are taking off like Thursday afternoon to beat the Friday traffic. Pretty soon we'll be backed up to Wednesday. Hi, Barbara.
Good afternoon.
Hey, Jackie's with us too. Jackie, hi, I'm Chris. We haven't met yet, but Jackie's a brand new person on our team, which we're very excited for you to be here. She's joining the Center for Aging and Health at the University of North Carolina at Chapel Hill, which is a mouthful, to do like data entry and special projects, right, Jackie?
Yep.
Nice.
Hi, Jackie.
Hi, nice to meet you guys.
Yeah, so a bunch of colleagues from University of Louisville, Kentucky, Barbara and Justin. And then right now it looks like we have 3 or 4 nursing home folks here for our discussion today, which is kind of a really good one. Because we're going to get to play a game, which I don't think we've ever done before in our echoes. Did we have any other announcement kinds of things that we had to do, Justin? I can't remember.
Other than talking about the virtual friendly visitors program, we don't really have any announcements.
Beautiful. Yeah. And I think I saw Sam showing up, and
yeah,
Pam's gonna be.
She'll be here in a little bit.
Nice. Okay, good. Hi, Sam. Yep. I love the yellow.
Thank you. Thank you.
It matches the yellow box that goes around you when you talk.
Oh, thanks everybody. Sorry, my internet's being a little weird today on my computer. So if you see me turn off my video, it's because you all are being a little choppy.
Okay. Well, I will let people in as they come in. But as always, this is Project Echo FlourishConnect. We appreciate you being here. And as we were discussing, I hope everybody had at least some time off for the Labor Day weekend. This is our maintenance phase. So this is September 1st. We'll be talking about an introduction to advanced care planning conversations. In October, we have Dr. Joshua, is it Niznik, sorry about that.
That's okay.
He'll be talking about polypharmacy and long-term care. And then our November session on November 3rd, we'll have Dr. Lori Earnshaw of Hospice Health here in Kentucky talking about transitioning to hospice care. So we hope you will join us for those sessions, and you'll be getting emails from me with reminders. And please, we'll have opportunities to present cases for all of those sessions, and as always, opportunities to field questions in advance. So please send us questions, send us cases, and we'll look forward to those conversations later this fall.
Yeah, we didn't have anybody that submitted a case for us today, but before we dive into Friendly Visitor and talking about advanced care planning and what matters most, let's just see if anyone has anything that's top of mind. It's been about a month since we've been together. So over the last month, have you had a patient question or a trend that you want to point out to the group, or just something that you've been noodling on, something you've been scratching your head about? Anybody with a case for today? And it can be about anything. It doesn't have to be about advanced care planning. In fact, this morning, we had a case about a grumpy resident, just grumpier. They all seem grumpier. So what's top of mind for you and your teams? What are you working on? What are you focused on?
We did have a comment about complaints of families cussing out staff has increased again.
Yeah, that was sort of the other side of it this morning, that everybody's grumpy, not just residents.
And Barbara's asking in the chat if anybody's concerned about monkeypox.
Yeah, has that come up for your facility yet? Staffing is still top of mind for Cynthia. Cynthia, you're absolutely right. Things are getting a little bit too physical, Kathy says.
Okay, we have a case,
Sure, Shirley.
or maybe just asking for some suggestions.
Okay.
We
Tell
have
us.
a resident that in the last couple of months has become very hypersexual.
Yeah, let's stop for one quick second. Somebody's making you echo, and I think that it
Okay.
might be your colleague's audio picking you up and feeding you back.
I think so. Hold on a minute.
Yeah, if you turn your speaker down, Diesta, then we won't hear Shirley twice. And I actually don't mind hearing you twice,
Okay.
but it's disconcerting to you. So go ahead, Shirley, try now.
Okay, is that better?
Yes.
Okay. All right. So she has become very hypersexual. We thought maybe she sees psych because she has some psych issues. So we thought maybe it was a difference in her medication. So we have adjusted those and DC medications that she was on previously. But it is every single day that we have to redirect her. We have to call family. We have taken meds, added meds. We have provided, how I'm supposed to say this bluntly without we have provided something to help satisfy the sexual urges. But at first it was any male in the building. It didn't matter if it was maintenance, central supply, other residents, visitor family members. It didn't matter who it was.
Yeah.
But now she's kind of fixated on one or two male residents alone. And it is all day long that she just says, I just want to touch him. I love him. And we are like, besides just continuously redirecting her, we are at a stop. We don't even know what else to do besides that all day. Yeah, we've checked anything medical, labs, UA, we've checked any of that. We've had medication reviews. We've had her son come even speak to him. And do you realize how embarrassing that was for her son?
Of course.
So
Yeah.
yes, we've had doctors, we've had social workers, we've had activities, we have supplied everything that we can think of to help this little lady.
Oh, Shirley, we're at a disadvantage today because I don't have an MD on the call with us. Because Dr. Citrone's not here, and I'm sure, Sam, I'm sure you've got something. I
Well,
know.
I've got a lot of questions first,
Okay.
and I don't know that I have a great solution, right? Because this is kind of a difficult situation. I will tell you that in persons with different types of dementia, we do see hypersexual activity fairly common, but probably not to the extent to what you're talking about. It's one of those behaviors that it does cause a lot of grief, so to speak, in nursing facilities and even in the community when people are living there as well. There's not been, there's been a lot of studies related to what causes this, because you were talking about, how do we uncover this particular piece? A lot of the studies.
She doesn't have dementia.
Oh, she does not have dementia. Are you sure? She's been properly assessed for dementia?
Yes, she's got schizoaffective disorder.
Okay. Missed
Yes.
that part of the story. Okay. So you can treat it similarly. Okay, because a lot of times when individuals have schizoaffective disorder, the part of their brain that is impacted is kind of similar to individuals who have different parts of their brains impacted by dementia. So even though this is a little bit different, and maybe this person's had other behaviors that now this one has replaced, in terms of, as they've gotten older, I would say that there's been a lot of studies done on pharmacological interventions, but not enough to really say, oh, this is what works with medicine. So those tweaks you're seeing might be making things worse, or exacerbating some of those impulse control related behaviors. A lot of times with individuals, they recommend having caregivers who are of the same sex as them, if that's their preference, if, in terms of if they're having those impulses towards the opposite sex, for example. So replacing those caregivers who might be male in that setting.
We have done that with the exception of therapy, because therapy is a male. So, in maintenance, and he's a male. So we kind of just avoid that part. So we do that.
Okay. And then the other thing I've read quite frequently is, and it sounds like you've already tried this, with redirecting to activities to occupy, because a lot of times they suspect that people get sort of not bored, but like they're looking for something meaningful. And that can be, any type of meaningful activity can be a replacement, but it sounds like you've already tried that. Is that correct?
We have, and we've actually, when we sit down to talk to her, we will say, why you can't do this, and she can spout off all the reasons of why she can't.
Mm-hmm.
And she says, I don't know why I do it. A lot of times I think some of it is, I know this sounds harsh, but for attention. But then most of the time I really don't think she has any control of it.
You can tell when she's manic.
Yeah.
She gets a little manic.
I mean, at points you can say, don't do that, and you're chasing her down the hall because she is headed towards that particular resident.
Mm-hmm. Yeah.
So,
yeah. And when did this start? Like, how long ago did it start?
it's been going on for about 2 months. She's been here longer than that, so it wasn't something she was doing when she first came in.
Yeah.
We actually had started her. So how it had started was a male, not even the particular resident that she is so infatuated with, but another male resident had become infatuated with her, and he was going to marry her and all this stuff. And she just flat out told him she didn't love him that way and left him, and doesn't have anything to do with him, but she has now turned that attention to a different male. Well, yeah. So it happened with that. And we had also had given her medication for sleep is when it had started. So we thought maybe that particular medication, so we stopped that. We had stopped it from the get-go, but there's no going back. It's only progressively got worse.
Okay. So I have another question. How old is this person?
She's, I want to say 65, but DS is checking.
56.
56.
56, so much younger. It has her hormonal levels been checked at all?
I believe so, but we will check and make sure.
Because if you're seeing some, like, to me, this seems like an out of the blue kind of situation, right? Like if she has been there for a while, not having these behaviors, something triggered this, right? So she may be looking at different imbalances that she might have, so hormonal changes that she might be going through that are exacerbating this piece of
thyroid, those type hormones and stuff. Is that what you're talking about, or anything in particular?
Well, also, I can send you a list.
Okay.
I'll get your email from Justin and we can check and see that piece. The other thing I want to say too is that as you get older, and even though she's not to like that threshold that we often talk about, but maybe due to her psychiatry history, we don't know what medication she's been on long term. And sometimes you build up almost like a toxicity to different medications, and it presents differently for different people. Right. So for her, it might be presenting as this particular obsessiveness, this lack of impulse control. And so that could be part of it as well. It could be that she's been on these whatever medication for a really long time. And that's what's causing some of this, because people change. Your body just, as you get older, naturally builds up either a resistance to it, or sometimes it can cause other changes. So I'd like to point you to the chat to Barbara's question about how much do you know about her psych history in general, and like what medication she's been on long term, because, again, this having it just be 2 months ago, having this, and she's presenting in this way without anything beforehand that suggested this, there's potentially something biologically going on or physiologically going on as well.
Yeah, and the reason I asked that question is because with her diagnosis, it's possible that she's exhibited this behavior before, and it could, it could be a trigger. It could be a number of different things. So knowing a little bit about her psych history would be really good and probably could inform you very well.
Yeah, that's a good point. And it could be a coping mechanism, right? Barbara's point about it being a trigger from something that happened. And so that's her way to express what's going on. And it could all honestly and again, I know that she has schizoaffective disorder, but with persons with dementia, which again, different parts of your brain are impacted. So multitude of factors that's causing it. Because we can't pinpoint it to one specific thing, but typically when it happens, it's sort of out of the blue in terms of a behavior. And then it becomes, maybe it was an impulse control thing in the beginning, but then it kind of escalates into being an obsessive kind of repetitive behavior that we see in individuals.
Okay, she's been with us 12/8. So this is, just a couple of months ago is the first. But prior to that, we do know she had an in-house psych stay somewhere else. And like one of the medications has been new since then. So
how long did you say she's been with you?
I'm sorry, Sam. You do have access to psychiatric services, right? You have a psychiatrist that can consult.
We do.
On that. Yeah,
Yes.
That's great. Go ahead, Sam.
What did you say in terms of how long she's been there? Did you say December?
December the 8th, yes.
December 8th. Okay. Yeah. So no, yeah, if you can have access to like those previous things to see what those behaviors are, I think that's valid as well. But again, knowing how long she's been on some of those medications, and I'll send you a list of things to also ask about. Because depending on if you have in-house psych now, if they weren't treating her before, they might not be aware of all the ins and outs too, and they might not have a comprehensive history. So they're treating what this emergent issue is, right? Because they're responsible for a lot of people. So if they don't have the full history, it'd be really important to get those records.
Other comments from the community or the hub team members? What else do you guys want to know, or what do you want to suggest?
I haven't had luck with this myself, but I did hear about another facility that they had a facility pet, and it was a cat, and they started having cat visits with this person that was exhibiting that kind of behavior, and it resolved it. Might be something worth trying.
Okay, get her a cat. I like it, Cynthia. I mean, we need a place to redirect our love is what we're kind of saying here.
I like that too.
Meaningful.
I'll check into that.
Wait, what, Sam?
I said anything meaningful like that can be very helpful.
Yeah. Here's the thing I was going to ask about, Shirley, and it's probably, I'm sure you've tried this, and I'm surely, it can't be this easy, but when the other resident was interested in her and she was able to say, I just don't have those kinds of feelings for him, can you flip that around so that when she's doing the behavior, I'm sure you've done this,
We did that.
he doesn't really have those kinds of feelings for you.
No, he actually told her that face to face.
Okay, good job. Yeah, no, yeah.
Politely and kind of gruffly. He's tried both ways.
And I would say probably because of her challenges in sometimes appropriately connecting with others because of the schizoaffective disorder, that feeling that she had, she can't necessarily understand how he feels about her. Like that's a broken communication skill that she might not be able to ever fully comprehend or understand that piece or make that connection that, oh, I didn't like this one person. And so, they stopped bothering me after I said this, but she might not be able to reciprocate that, on the reverse side of that or truly understand that piece.
Yeah, I knew it was going to be too easy, and I knew you had already tried it. And good for him for standing up for himself. Okay. Other thoughts or helps for Shirley and Diesta? I was looking for the Teepa Snow video, folks, that I think we saw a couple weeks ago, a month ago, on dealing with hypersexuality. I can't find it, but I'll do some quiet YouTube Googling because some of that stuff may also, I remember the video, I just can't locate it at the moment. And not to make too much of a segue here, but this really matters to both of these people. And that's what we're going to talk about today, is what really matters. But Justin said we had a friendly visitor program announcement opportunity.
Barbara, would you like to talk about the Friendly Visitor Program?
Sure. So I'm sure all of you all are familiar with the Friendly Visitor Program, face-to-face visits in your facilities as well as in the communities where volunteers come and you know, meet with the residents and befriend them. During the pandemic, we had the opportunity to create the virtual Friendly Visitor Program, which is the same concept, except we do it using technology. We do it virtually. And basically, the goal or the main purpose for the program is to reduce social isolation. And of course, social isolation increased for everybody, and particularly for nursing facility residents during the pandemic. But we all know that many of our residents were socially isolated even before the pandemic for a host of reasons, not necessarily because they didn't have family that cared or whatever, but sometimes family lived out of town. Family, you know, had life circumstances that just didn't allow them to frequently visit the nursing facility, and others just didn't have a lot of family or family at all. So we're continuing the virtual Friendly Visitor Program. We do it both in the community and in nursing facilities. It's a relatively small program now, but over the past couple of years, it's evolved, and many individuals have been impacted positively as a result of this particular service being available. We want to make the virtual Friendly Visitor Program available to you in your nursing facilities. It can occur in a number of ways. I do want to say this morning a question was asked, and it was a good one, is do you also do face-to-face? And if we have students in your area, in your community, of course, in Kentucky, then yes, we could offer the face-to-face visit, but we do know that nursing facilities are located everywhere. And of course, we have our North Carolina partners. If you are interested in this program being available to your residents, then we can offer that support through our volunteer virtual friendly visitors. We're getting ready to train a pretty large cohort of students this academic calendar year, actually in the next week, to we're going to train them to provide this service. So there'll be enough volunteers available to meet the need and in a number of nursing facilities if we have that kind of interest. The goal is to reduce social isolation and to help that individual also build additional connections, social connections, through using the technology that they're provided or the technology that they already have available. So in Kentucky, if your residents have smartphones or if you have telehealth capacity that they can utilize to meet with their friendly visitor, wonderful. If they don't, we do have tablets that we pre-program and allow the participants to utilize so that they can connect with their friendly visitor. If you're in North Carolina, obviously we won't be able to send tablets across the state line, but again, if your residents have smartphone or if you have telehealth capacity, then they would be able to participate in the program through those means. The students that we're training are bachelor's and master's level social work students, and they'll be trained pretty comprehensively so that they know the nuances of the program, but also any restrictions, et cetera, that need to be, any policies, procedures, protocols that need to be followed. So that's the virtual friendly visitor program. You see the contact information here on the slide. Justin also put it in the chat. So if you're interested, you can contact Justin or myself or Chelsea Maselli. Chelsea is our program coordinator. She lives in Eastern Kentucky, and she's helping us to coordinate this program as well. So you can contact any of us and we will share more information with you about how to get started with the program and how to engage the residents that you feel might need a service like this. We've done it in nursing facilities in Kentucky already, and it has been quite successful. In Eastern Kentucky is one of our first pilots in nursing facilities in Eastern Kentucky. And I actually used HOSA, that's Health Occupation Services Association, and high school students as the volunteers to those residents in the nursing facilities. And it worked quite nicely. And we also work with Presbyterian homes here in the Louisville area. But definitely want to connect with you and offer this program, this service, if you feel your residents could benefit from it. Thank you. Any questions also?
And Sam is going to launch a poll, just a really quick poll to get an idea of what you know, if you're already using virtual friendly visitor programs, and a couple different questions.
And you all should be seeing it on your end now.
As you're completing the poll, I'm going to just talk briefly about, as always, we have a brief survey at the end of today's session, and that is required if you'd like to receive continuing education, and we do really appreciate your feedback. And as always, our continuing education is provided by the Southern AHEC in Kentucky. So today I'm gonna provide a brief introduction to advanced care planning conversations, and we're gonna do an activity at the end to sort of give you an idea of things that you can do with your staff and with your residents. We're gonna talk about the importance of advanced care planning. We'll talk about increasing our comfort talking about end-of-life wishes and have a brief activity. And we'll review some additional advanced care planning resources, realizing that there are so many needs that need to be met and different individuals at different points in their ability to make decisions for themselves or understand decision making, that there are some resources that you can access that can help in those areas. So I really love the way Osmel and her cohorts explained advanced care planning. It's an ongoing process of communication between healthcare providers, the patient, and the family to clarify their understanding, wishes, and values, and potential concerns about treatment and care at the end of life. And so I think that as we think about this as an ongoing process, this really is something that can happen over. In my fantasy world, this happens over the lifespan of an adult. As soon as you're out of college and you're basically needing to go out into the world, when you fill out an application and you have to say who your emergency contact is, if that person isn't married to you or a direct family member, that person needs to know what your advanced care planning wishes are. And if they're your contact, they need to be able to make decisions. And so this is something that I think many adults don't engage in, myself included when I was considerably younger. The reason this is so important to me is when I was 25, I had no experience in healthcare really. I had no experience in making healthcare decisions, and I became my grandmother's healthcare surrogate when she admitted herself to the hospital and became delirious. I was her closest next of kin. And the only information I really had was that she was had a do not resuscitate order and would want to go home at any cost. And so I use that as really my calculus through the decision-making process. My dad was there to really help me problem solve, but at the end of the day, it was on me. My parents or my dad and my stepmother were busy raising a family. I was my grandmother's closest next of kin. And the decision making and most of the visiting fell to me. So I was navigating, living in Louisville and going to rural Indiana to visit the hospital at first, and then she moved to rehab to ostensibly go home, and eventually she died in a long-term care facility. And so I saw myself having to make these decisions without really understanding the information that was being presented to me. I saw healthcare providers sort of ducking the questions I would be asking around her diagnosis and her prognosis. And then at the end of her life, when she was speaking to my long dead great grandfather, the long-term care facility not really knowing how to talk to me about hospice care or end-of-life care. And I left the situation really feeling like I'd failed and pretty angry at the system. So it's taken me a long time to really build empathy, to realize that many people avoid these conversations. And I can also see how this really ties into age-friendly healthcare concepts, because advanced care planning conversations and end-of-life conversations can touch on all these domains. We often focus on what matters, but you can see how someone making decisions about the amount of medication they're receiving for pain reduction, for example, can directly tie into these conversations. When you think about mentation, you want to be having these conversations when a person is decisional, and as their capacity changes, being able to really go back to conversations that they've had with their loved ones and their healthcare providers can really help support decisions that are made in their level of care. As mobility issue changes come about, that may change, or maybe healthcare status changes, that may change the level of care they would wish to receive. So you can see how these age-friendly concepts are really all tied up into this conversation. And so, again, it took me some time to really sort of give myself some grace that I wasn't really able to engage in these conversations. And the Conversation Project has really, and actually going on and talking to people in the public, has really given me a lot of perspective that only 32% of the general population have had advanced care planning conversations. So that tells me that there is a large gap to be filled, and there's a lot of room to learn in this. And Barbara, myself, and a lot of the Traeger staff were just at our state fair, and I introduced the idea of living wills to many people, and we were completing living wills there. We actually completed 50 in 2 days, but the number of people that looked at me like like no way, was, there was a high number of people that looked at me that way. There were many people that would even talk about having COPD and other chronic diseases, and they still didn't want to talk about it. They didn't want to hear about the importance of it. So I can look at this and see that, only 32% of the general population has had this conversation. It's hard to find numbers, and I have not found any about the number of conversations that occur in long-term care. I'm assuming it's higher, but I would still think that there, are still lots of things, barriers to both staff and the public that really help prevent having these conversations and documenting them. The nice thing that I learned about the Conversation Project is that most Americans say they recognize these conversations are important, and 95% would be willing to discuss them. This last number, 53% say it would be a relief. My judgment here is I haven't seen numbers to say how many people found it to be a relief after they had it, but my guess is that many people would find this to be a relief to actually have these conversations. And so this comes from the Conversation Project in 2018. I looked at their numbers from 2013, and most of the numbers had stayed pretty consistent. But in 5 years' time, and their collaboration with the Institute for Health Improvements, they had moved the number from 27% of the population to 32%. So you can see that even with big public health campaigns, it takes time to move the needle here. So just some ideas around the benefits of this, basically increasing goal concordant care, reducing stress and conflict for families and loved ones. I was very fortunate in my case that no one in my family really conflicted with me. But I hear stories all the time, like for example, in Kentucky, if an adult is unmarried, if they are not married but they have adult children, their adult children would be their healthcare surrogate if they haven't appointed one. And so what you'll often hear is you'll hear of 3 or 4 children that are adults who are basically fighting over what to do with their parent, what decisions to make. And it can really create conflict as a loved one is going through a health crisis or their health is deteriorating, but then it also creates stress for the staff. It also creates stress for the staff when they are having to deliver care that may conflict with what they think is in the patient's best interest or in their or represents their values. You can also see that there are some benefits to decreasing hospitalization when people have had these discussions and they've been documented. So there are lots of benefits. The conversation piece is really, and the ongoing conversation piece is really the crux of this, although the documentation piece. And because of differences between states, we're not going to get too in the weeds about the documentation piece, but I will be giving some resources at the end. And if we can ever help you find resources around documentation and how to implement that into your policies and procedures and your workflow, we would be really happy to do that. So today we're going to play an activity. This is an advanced care planning tool called Hello. Well, basically we're doing the virtual version called Hi, but Hi is based on Hello. It is basically a booklet that is used to guide conversations, either one-on-one or in small groups, but it really offers a wide range of topics and conversation starters around people that are facing the end of their life. And we'll talk about some of the questions as we're going through this, but you can see some of the questions over here on the right. Who haven't you talked to in more than 6 months that you would want to talk to before you died? And question 5, if you needed to go to the bathroom today, who is the first person you would ask to help? So you can see that the questions aren't totally directed towards naming a healthcare surrogate, but as we go through and play the shortened version of this later today, this afternoon, you'll see that those questions show up, and it's really a way to build skills. As a team, it's really a way to build intimacy and having conversations with residents and their loved ones. But Common Practice has worked with the University of Pennsylvania to do some research on working with both people in the community as well as professionals, and they found that across the board with their studies of people in the community, basically it increases advanced care planning behavior and completion of documentation. It increases reported self-efficacy of patients and loved ones to have these conversations. In a focus group of over 230 people, no group participants reported the activity as burdensome. For people living in community settings, and this also includes retirement settings, they have also worked with long-term care facilities. The activity has been perceived as well received by the participants. And of healthcare chaplains who have participated in the activity, they've showed increased confidence in having end-of-life conversations with peers and patients, and also reported the game to be a positive experience and useful tool. So I'm going to talk a little bit about how advanced care planning tools have been used in long-term care. But as I transition into that, what challenges and barriers are you seeing? And you can put this in the chat. I'm really curious. What I've always heard as someone who has volunteered in long-term care facilities with hospice organizations is, and I've heard this from other long-term care directors, that if you've seen one long-term care facility, you've seen one long-term care facility. So if you don't mind putting in the chat, what are some challenges? What are some things that you would be supportive? So I looked at several studies that were considering advanced care planning in long-term care, and Sussman and her group looked at using tools in long-term care facilities such as Hello. They use many games or many types of games and activities and different toolkits. And what they found is that advanced care planning information and direction were really key in success, but also that tools with psychosocial focus were also very useful. So if they just focused on getting, and I see that, Shirley, getting families to agree on things. I think as we talk about some of the tools out there, I think you'll see that there are some ways that we can, and my lights are going out, I'm sorry, hold on just a second. as we're looking at these different tools, you can see that there are ways to engage, but getting at least one person assigned as a healthcare surrogate when the person's decisional can really help take away some of that. But yeah, I can definitely imagine that. But basically combining the very basic information that's in an advanced directive with more psychosocial information can be really useful. They also talked about having different types of tools. So many of the tools now are moving towards an online format, and that can be off-putting or challenging for many individuals. So having tools that can be also printed or on paper, and again, Hello is paper-based, and the conversation project which Chris put in the chat, which we'll give you also at the end, is also, you can do it online or have a paper-based version. So there are different things that you can do and different options that can make this easier and more accessible, and also making sure that it's not too long. The nice thing about Hello is this can be revisited and updated over time, so it doesn't have to be done all in one setting, but just making sure that you are gauging this if you're working directly with residents and their families and you're not overwhelming them. So Sulman and her team were looking at some of the benefits, and they basically had a control group and they had a group that received their education intervention. And the intervention group showed that nurses and families were more satisfied with communication in the group that was receiving the education. The training reduced staff distress, but this weakened over time. So what it showed was that over time the training needed to be revisited, and that the training really did reduce staff distress, both over discomfort having the conversation, but I'm assuming also interacting with families that maybe, to Shirley's point, understood the value of this and understood making decisions as a group. And one of the things that was really overall pretty overwhelming was that this is a team approach. You heard Dr. Morton talk about that in her falls prevention presentation last month, but that advanced care planning is a team approach. And this can go from everything from the activities director to even basically what one of the studies was looking at, that it often falls to nurses and doctors, but there are many frontline workers who are not nurses who are having parts of these conversations and can actually maybe help reinforce and support this. And so not just putting this off on any one department, but really spreading this out. We had a member earlier today in today's session who used to work at Nazareth Home, and she talked about it being a culture. And so when someone came in that was new, really acculturating this as being part of the conversation and really embracing this at all levels. It's not just any one department, but really leadership and at all levels of the organization to make this more of a team-based approach and really increase the comfort with it. So we're going to just take a few minutes and we're going to get introduced to HI. And so HI is the shortened version of Hello. Hello is 32 questions long. I'm going to give you a couple of just questions that are from HI to give you an introduction to this. The most important part of this is learning to listen, but you're always able to pass if you don't want to read an answer. There are no wrong answers, and you can change your answer at any time. So this is very important, that sometimes I may say something and then Chris will come behind me and give an answer, and I'll be like, oh my gosh, that was way better than my answer. And it's not about that, but if Chris gave an answer that really touched me, I can change my answer. I could basically not be fixed on what I had originally said. So because we're a small group, we're going to stay in one large group, and I'm going to ask the FlourishConnect staff just to listen. And so the participants, basically, I'm going to ask you a series of questions. If you have the ability, please write down your answer. And if you're able, you can unmute and share your response. That would be really appreciated. You're also welcome to put it in the chat. If you're either unable to unmute, or you don't want to speak, you can also put your answer in the chat. So again, common practice presents this like it's a game. And I think sometimes people get a little weirded out by that. Like, I'm going to play an advanced care planning game. I consider it an activity, but there is turn taking. If we were in person, I would have a token. And if somebody said something that really touched me, I would give them the token. And that, to me, at first, I thought it was really kind of corny. But when I've seen it play out, you can see groups really get into like this sharing where, like, if Carmen said something that really touched me or really struck me as vulnerable, and I honor that, other people get in the habit of that. And so they start speaking more directly, more from the heart. And it becomes like this activity where you know, like, you're really sharing about things that maybe you wouldn't have that everyday conversation. And so we are able to do reactions. I was not able to do that for some reason this afternoon. You're always, you know, welcome to throw out a reaction if somebody says something that touches you. But how this will work is I'm going to ask the first question, and then I'll answer the question, and then I'm just going to go around and call on the attendees. And if you're welcome to unmute, or you can put it in the chat, and then each person will kind of answer, and then we'll move on to the next question. So the first question is, write down any hopes you have about playing this game. So write down any hopes you have about playing the game. And I'll give you just a little time to answer. And so I'll start for question 1. And as the facilitator, I always hope to get a little more clear about my facilitation skills. And I also love to learn from other people and hear other people's ideas and insights. So that's what I hope to play and get from playing this. Shirley, is there anything you'd like to share?
I actually had that as my
And if you put it in the chat, I can also read it off. So you've, okay. Cynthia, is there anything you'd like to share?
I just put engaging. I hope that it's engaging.
Okay. And Shirley just put in that she had that as her second thought. Crystal, is there anything you'd like to share? Well, Crystal, if you have anything, you're more than welcome to put it in the chat. Kathy? Carmen?
Yeah, I already wrote that, and I looked up the game too. I think it would be good to communicate with family members, and I think a lot of our residents, the ones that don't have dementia, would probably enjoy this.
Thank you. And so I'll also mention some resources at the end for people with dementia, because I think that's really important. Diesta says, understanding things that I'm uncomfortable talking about. Shirley said, I'd just like to learn what other people have to offer and how they deal with everyday situations. And Kathy is saying that she just heard of the game and she's interested. Yeah. So, and this is, you know, this is just, you know, getting us started, thinking about, you know, what do we hope to get from this? Second question, who haven't you talked to in more than 6 months that you would want to talk to before you died?
All right, Justin, do we have to name names, or do you just want to know the role of that person?
People can be as vague or as crystal clear here as they want. So
Okay.
Who haven't you talked to in more than 6 months that you'd want to talk to before you died?
That could be a pretty powerful question depending on who you're asking, because we have had people, just residents, that have said that they wanted to reach out to either a sibling or someone in their family that they had not talked to, and they just wanted to reach out before they pass. So that can be pretty powerful.
Yeah, I agree. Thank you. Kathy, is there anybody you'd like to talk to? Coming from the chat, nobody. I make an effort. Somebody said something very similar earlier today, Shirley. They'd make an effort to talk to everybody they care about. And Diesta said no one she can think of. And then Cynthia said her college best friend. Is there anybody else, anybody would like to either put in the chat or unmute and share? My social circle is very small. Still thinking about it, a bestie who lives in Washington State. I usually say my ex-wife here. I haven't talked to her in a long time. You know, it's, I don't know, like it would be something that it would, you know, like maybe die with a clear conscience or something. So, and this is where it starts to get into the advanced care planning piece, and I'll put a few more of the questions in the chat. But next question, name the 3-person committee who should be consulted on any decision made about whether to continue life-saving care if you couldn't communicate. And let us know who the head of the committee is. So the 3-person committee who should be consulted on any decision made about whether to continue life-saving care if you can't communicate, and let us know the head of the committee. Does anybody want to get us started? Yeah, so Shirley's saying her daughter, her husband, and her sister-in-law, with her sister-in-law as the head. And so as we're thinking,
I'd have to have 4 people because I have 3 kids. I couldn't exclude one of them, but I would want my husband to be the lead.
Okay, yeah, and that's, you know, I mean, we're all situations are all a little different. Kathy saying her best friend or son and husband will try to keep me alive as long as possible. So not your hubby. I think, and that's very normal. And I think that being able to communicate that has such value. And if you need to assign a different person to be your healthcare surrogate, being able to know that ahead of time and dictate that is very important. Anybody else want to share who would be their 3-person committee? So my wife, one of my closest friends, Chris, and our medical director, Dr. Furman. And my wife would be the head of the committee, but she knows to ask Dr. Furman what my chances are and what my prognosis looks like, because she'd shoot it straight. But I think it's really important, you know, for her. My fear is that she would maybe go a little further than I would want, but, you know, I think those other people could keep her in check. So Carmen's saying your husband and 3 children. We have had a clear conversation with our children and spouses and have forms in place. Yeah, that's great. And realizing that this can change over time. Your values can change. The people in your life can change, or your health situation can change. And so this can always be revisited and updated. Is there anybody else that wants to share anything about who would be part of their 3-person committee? So I'm going to put an example of question 6 and question 8 in the chat. And this will give you a little bit more of a perspective about, you know, how, you know, this really gets into some of the psychosocial questions. It really gets into some of the questions around, you know, what do you want? You know, the assumption is somebody wants to die with somebody at their bedside. And I recognize that not everybody feels that way. It gets into questions like that, like who would you want with you? Would you want music playing? It really does look at a broad variety of questions. And it does come back to the questions that would show up on an advanced directive or a living will as well. So it is a pretty broad-based tool. And again, you know, the virtual version high is only 8 questions, but the Hello game is much broader and can be played over time. And again, the nice thing about Hello is that it is a tangible thing that people can have, and it can be transitioned to doing this. Chris, I would eat ice cream. That's the only thing I would eat. Like if I knew I would eat ice cream until I was sick of ice cream. So any questions?
This is a really interesting way to open this door. Desta, you were saying earlier that, you know, these are hard things to talk about, and it feels awkward, and like everybody procrastinates on this. Like we all know we should do this. So I think this is kind of fun. Carmen's going skydiving because you're going to die in 3 months anyway, Carmen. So you might as well jump out of a plane.
I'm terrified of heights. My kids are, and their spouses do triathlons, they skydive. So I figured if I have a heart attack from fear, I got 3 months anyway.
Yeah, people talk about like the bucket list, that you should do these things before you kick the bucket. I would even go so far as to suggest that you should do those things now, not necessarily skydive if you're really terrified of it, but don't wait. Go to Israel, deep sea fishing. Ooh. Anybody else got a bucket list thing they want to put out there? These are fun.
My daughter, who's the fearless one in the family and starts stuff up, had said, you know, let's just start small. So the family is going to go do Angel's Landing this fall, which it's in Utah, it's in Zion. And if you look at, you know, the last part of it, it's, I don't know. I told her I would do it, but I may not be the same when I come down. But like, you know, they've been very much of encouraging us, like, you know, we all have to go do this now. And it's become like a family vacation thing that we all do these things that are fun for everybody. And it's really bonded and brought in not just our kids and their spouses, but we've adopted some of their friends that say that this is a lot more fun than their family vacation hanging out at a pool.
All right, bucket list items on your next vacation. Carmen, I really like that idea.
So here are some resources. Again, we recognize that there's not going to be a one-size-fits-all tool for either facilities or people in, you know, regarding the state they live in, or even, you know, their residents. So the Kentucky Most Coalition, if you're in Kentucky, has a lot of great resources around advanced care planning conversations, and the Kentucky Most Forum. We also have a good example on here of a policy and procedure of a nursing home that's local here in Kentucky. The North Carolina Partnership for Compassionate Care has a lot of great resources as well. I know we often have people from Massachusetts. Honoring Choices Massachusetts is a great resource. National Pulse, if you want to find direct resources in your state or find out more about Pulse documents. And so those are medical orders around end-of-life wishes that are available in most states. You can visit National Pulse website. Chris put the Conversation Project in the chat. They also have some great resources that are in, you know, many languages, also for people with dementia. So they have lots of resources that, you know, can meet different needs. The 5 Wishes document, if you're not familiar with it, is a nice resource, and it's also it's fairly universal. I think it's recognized in 45 states. And then Common Practice is who develops Hello. And if you would ever like to use Hello with your staff or with your residents, definitely contact me. We can help connect you with that. And I think we have some funds that can maybe help support that as well. So please reach out. here's our case study form as always. You know, again, in October, we're going to have a great presentation on polypharmacy by Dr. Nitsnik. I'll get it right by then. Is that close?
Yep, you were good. Niznik.
Niznik. Okay, so yeah, Dr. Niznik will be here on October 6th. And then as always, if you could complete this short weeks 26 session survey, I will put it in the chat. We really appreciate that. And we'll get your continuing education certificates out in the next couple of days. We'll be able to hang out for a few minutes. So if you have questions or comments, please feel free to hang out. We really appreciate you engaging in this and hope that you find some value and using these types of activities to get these end-of-life conversations started.
Yeah, it was super fun for me, especially. Jackie, do you have a couple minutes to hang out? I want to hear what you thought of our session because this was your first